We're going to talk a little bit about some pretty basic vascular abnormalities that you may encounter on the surgical floors or in the emergency department or in the ICU. Some things that you can really quickly identify and define with bedside ultrasound that otherwise might take you a while if you're waiting for the vascular lab to be open during regular hours or you've got to call in other folks. If you have some basic skills with bedside ultrasound, you can solve a lot of the acute vascular problems that you're presented with at the bedside in just a matter of minutes. Some of the reasons you might take a look at some of these things: patients have a cold limb or a painful limb, you're worried about ischemia, aneurysm, pseudoaneurysm, so maybe they've had a femoral puncture and now they've got a lot of swelling and you're concerned, or dissection, fistula. All of these things you can pretty much solve in just a few minutes at the bedside with a few basic ultrasound skills. And really the basics of the technique are: find the artery of interest, apply color, and examine it from above, through, and past the area of concern. Sometimes you may need to use other pulse wave Doppler techniques, but most of the time just examining the vessel and applying color will help you solve the problem and figure out what's wrong. I will point out that it's worthwhile to try to make sure you have your machine in the correct setting. So place it in a vascular setting so that your scales and your color gain are set at about the right spot. But it is worth being familiar with how to change your color scale and color gain a little bit to help optimize some of your images. I'm not going to get into a lot of detail. Be mindful of that, pay attention to those settings, and play with them and understand how to manipulate them a little bit. So the first thing is arterial ischemia. Mostly you want to decide, is this acute critical ischemia versus is this kind of subacute or chronic or non-critical? And there's a big difference between having some flow and no flow. So first things that are going to happen when you start to lose flow in a limb is decreased arterial velocity. At some point it may become more monophasic, and then eventually to the point where it's absent. If we get to the point where it's absent, we definitely want to know about that. And if you're not sure, you can always kind of look at the unaffected side and compare. Make sure, again, you know how to lower the scales and turn up the color gain to help improve your sensitivity, so you don't make the error of saying there's no flow when really it was just low flow and your scales and gain settings, things weren't adjusted so that you could see that. So arterial aneurysm is one of the easier things. Again, if this is a concern, maybe it's someone who's had a knee injury in the past and now they're having some lower foot pain or something like that. You really just find the popliteal artery and follow it up and down, or whatever artery you're concerned with. You're going to see a focal area of dilation. And then you may put color in that to see how it swirls and make sure it's a true arterial aneurysm or not. Pseudoaneurysm, this is probably one of the most common things that you'll be seeing and be asked to check for because the patient's had some kind of puncture and now they've got a lot of swelling and maybe it feels pulsatile on exam. Again, you find the area of concern, you follow it, you place color on it. If you see what looks like a hematoma, so a dark area near the vessel, but then when you apply color, it has color flow within that hematoma, then that's a pseudoaneurysm. And I often describe it as a hematoma that has flow. And if you're very careful and follow the vessel near it, sometimes you can actually find the defect in the vessel. And if you get the right angle, you'll get this textbook yin-yang appearance where the blood flow is kind of flowing in and out of this hematoma. And you can very quickly rule in or out this complication of puncture of pseudoaneurysm with some really basic bedside ultrasound. Find the area of interest, follow it up and down, apply color, make sure you can adjust your scale and your color gain to help you improve the sensitivity for this stuff. So here's just a live image of a pseudoaneurysm. So we've identified the vessel here. This is the vessel. This is that large area of quote-unquote hematoma, but it's not hematoma because it has blood flow through it, flowing in and out. This is a pretty sizable pseudoaneurysm. Again, diagnosis that you can make in seconds at the bedside with some very basic ultrasound skills. Sometimes you may be asked to check out a dialysis patient who they're having trouble with their AV fistula. Another thing that you can very quickly and in seconds figure out, is this fistula thrombosed or not? Is it partially thrombosed, completely thrombosed? Does it have hematoma around it? All these things. You find the area of interest with ultrasound, you follow it, you apply color, and you'll make this diagnosis in seconds. Here's the patient's native artery. Here's their fistula that's completely clotted off and not functional whatsoever. Sometimes you may develop AV fistulas as a complication, often iatrogenic from femoral sticks, probably because you didn't use ultrasound to look at where you were going. Same thing here, you really just find the area of interest, find the vessels, follow them, apply color. Sometimes you may need to apply Doppler. What you'll notice is you may have normal looking arterial flow, But then if you look at the vein itself, it may have much higher velocity flow, and if you put pulse wave Doppler in it, you'll see probably higher velocity and maybe some pulsatile quality as well. And then another thing that can be pretty easily recognized is dissection. This can happen due to trauma or injuries, or it may be spontaneous, maybe extending from an aortic dissection. This example here is a carotid, and really you just find the vessel of interest and look for a flap. And what I'll point out is a dissection flap will usually flap and move with the cardiac cycle. Now that may change depending on how long it's been there. If the false lumen starts to get thrombosed, you may not see as much movement, but in the acute setting at least, you'll probably see some moving of the flap with the cardiac cycle. And you can apply color to see that there is flow in both the true lumen and in the false lumen. Watch out for artifacts, because sometimes you can get artifacts that will fool you. And that's really it. Most of the important, immediately necessary arterial disease things that we need to answer at the bedside really just involve finding the vessels of interest, following them, and applying color. Always start with the history and physical so you know what questions you're trying to answer, and then find those vessels and see what's going on with them. Make sure you're familiar with your color gain settings and your scale so that you can identify some of those low flow areas, and don't make the mistake of saying there's no flow when really it was just low flow and you needed to adjust your settings to identify that.